When a mother dies, especially in pregnancy and childbirth, the whole family dies along. I'll put my focus on the 3 health-related Millennium Development Goals. As you now know, goal number 4 is about reducing child mortality rates. Goal number 5 is about reducing maternal mortality ratio.
South Africa has a very high level of maternal mortality, neonatal mortality and child mortality for a country of our level of development. So it's very important for us to firstly understand what are the causes of mortality and what we need to do about it. And we know that now. We know what the causes are, we know what we need to do about it. But what we needed was some additional assistance in order to implement the interventions that we already had designed. And the RMCH project, with DFID's funding, has been instrumental in assisting us to implement those interventions in facilities and at district level to realize some of the maternal mortality, the neonatal mortality and under 5 mortality gains that we wanted to achieve as a country.
RMCH in full stands for Reducing Maternal, Newborn and Child Mortality in South Africa through Strengthening Primary Health Care. This program was conceived by the National Health Council in South Africa. It is a partnership between the UK government and the South African government to reduce the high numbers of maternal, newborn and under 5 child deaths in the country.
If you want the national averages to go up quickly, you must go for where the biggest problems are. So we did do that deliberately. So we chose the districts that were the worst performing from the indicators that we had, and we had RMCH go and work in those districts. The reason that these are districts that are not performing very well is either they are poorly managed, or they have few resources, or the burden of disease is very high, or it's a combination of all 3 things, which is mostly typical of the districts we chose.
The RMCH program provides technical assistance to the South African National Department of Health and districts to improve the quality of and access to reproductive, maternal and child health services for women and children living in poorer, underserved areas in South Africa. This is done through supporting primary healthcare re-engineering. To address the high rates of maternal and child deaths in the country, the Minister of Health launched an initiative to restructure the primary healthcare system. This initiative is known as Primary Healthcare Re-engineering and is made up of 3 streams. Within healthcare facilities, the District Clinical Specialist Teams, or DCSTs, play a key role in ensuring the provision of quality maternal, newborn and child health services at all levels within the district. An ideal DCST is composed of up to 7 medical specialists who work to improve the quality of care and clinical governance in district facilities. Within communities, the strengthening of school health services contributes to improving health and learning outcomes for children and youth. And at the household level, the ward-based primary healthcare outreach teams, or WBOTs, play a key role in delivering community-based maternal and child health services to communities and households and facilitate access to services at primary healthcare and hospital levels within electoral wards. The RMCH program supports primary healthcare re-engineering through its targeted technical assistance approach. The RMCH Technical Assistance Package was conceptualized to address 3 strategic gaps: to facilitate the translation of knowledge to action by making national policies accessible to frontline workers, district managers and provincial leadership; to strengthen local leadership, accountability and capacity for these policies to be successfully implemented; and to strengthen healthcare service delivery systems and processes within the district health system. The RMCH technical approach was targeted at 3 levels of implementation: the national, provincial and district levels. At the national level, RMCH supported the National Department of Health to strengthen the planning, monitoring and coordination of maternal, newborn and child health programming. This was done through raising awareness of the value in the demand for and use of data to track progress and review policies. RMCH led the development of the Maternal, Newborn and Child Health and Nutrition Dashboard. promoted knowledge sharing, and conducted national evaluations, such as the Maternal and Child Health Strategy and the review of the district clinical specialist teams, in order to inform policy improvements. RMCH technical assistance focused mainly at the district level, where the program support aimed to strengthen local leadership, primary healthcare service delivery, and clinical governance in 25 priority districts that showed the highest maternal, newborn, and child mortality. Within facilities, RMCH provided technical assistance to strengthen leadership in clinical governance and clinical care through the recruitment, training, mentoring, and coordination of district clinical specialist teams. Through the DCSTs, RMCH facilitated quality improvement interventions in 308 high-burden facilities to improve the quality of care and maternal, newborn, and child health outcomes. Within communities, RMCH facilitated better coordination in the implementation of the Integrated School Health Policy through technical assistance to establish and strengthen district and provincial task teams and establishing school-based support teams. To increase the demand and use of school health services, specifically for sexual reproductive health services and family planning, RMCH facilitated engagements with school governing bodies and communities. In this way, RMCH reached 599 schools and more than 115,000 learners and adolescents with health education messages. At the household level, RMCH strengthened ward-based outreach teams and community health workers to effectively promote family planning and maternal and child health services to communities by translating the family planning policy into job aids and training ward-based outreach teams. As a result, over 9,000 family planning materials were disseminated and over 1,000 healthcare and community health workers were trained.
So in overall, what we've essentially achieved there is the DFID's strategic objectives for the country. In ensuring that we have translated policy through knowledge, evidence into action and implementation. 2, we have strengthened the current existence of poor leadership accountability through strengthening the 3 streams with a focus on strengthening clinical governance, clinical care through the DCSTs predominantly. And then lastly, we've supported the 3 streams to deliver high quality, high impact interventions shown to reduce maternal and child health by supporting the 3 streams and providing districts with and leaving probably behind a legacy that RMCH would like to leave behind through the technical assistance design and approach that we would like to believe that we have created an enabling environment for rapid scale-up of maternal and child health effective interventions.
The RMCH program is implemented through a partnership between the Palladium Group, formerly known as Futures Group, which is the managing partner, and Health Systems Trust, Save the Children UK, and Social Development Direct. The program is funded by UKAID. Each partner was responsible for implementing a different objective of the program.
As we were developing the primary healthcare re-engineering system, we appointed district clinical specialists, and RMCH has been really central to both the implementation of this part of the program and also the empowerment and working together with the district clinical specialists.
HST's role in terms of supporting the DCST program was really to help ensure that there were functional DCST teams operating in the targeted districts, and there were about 25 high burden districts which had been targeted for support from the RMCH program. And so that involved training, orientation, capacity development, mentoring, and support of these district clinical specialist teams. And at the end of the day, it also depended on the district's ability to recruit and place the relevant specialists, but once they were there, then to provide them with the necessary support so that they could then provide clinical support and oversight to other personnel providing maternal, neonatal and child health services at the district level.
In terms of supporting the DCST coordination, RMCH has been involved at all levels. Facilitation recruitment that would be in terms of assisting with identifying, looking at the CVs, the suitable candidates, liaising with the provinces in terms of fast-tracking the recruitment processes, and also sort of directing to the districts in need, you know, that or motivating the specialists that there is a post in such and such a district. So I've been working very closely with the provincial DCST coordinators and the provincial specialists. The other role in terms of coordination is the whole technical assistance approach, coordinating the reporting, what are the DCST activities, creating an enabling environment in terms of creating the understanding for the district managers, other program managers, even within the National Department of Health, representing the DCSTs in core, core structures. In fact, RMCH is the one that did the whole 5-module induction and orientation, except in the KZN, because KZN had different funding for that. There was the induction and the orientation program that ended in June 2014, but there are new members that have joined since then, so it's mainly liaising with the provinces and supporting them in making sure that the new cadres are also inducted and orientated.
So one of the key interventions from RMCH from the beginning of the project was to work with us as we were appointing members of the district clinical specialist team, to orientate them, to support them, in some cases to train them or retrain them. And we now have not full teams in every district, but at least every district has a few members of each of the teams that we had planned.
I think we needed induction because we were from different settings. We were not working in clinical governance. Most of us were clinicians, some were in hospitals. So the induction helped us to know what do we need to do, what is clinical governance, and so that we focus on the job that we have to do, because before we were not clear on our role.
We worked very well with RMCH and we are still working with them even though they are out. But the few that are remaining at National, they still support us. When we started with appointment of the district clinical specialist teams, they are the ones who came and clarified the roles of the RMCH, of the district clinical specialist teams, and they made sure that they implement whatever they're supposed to implement in supporting facilities, primary health care, in terms of reducing maternal and child health. Already the RMCH developed the handbook for district clinical specialist teams.
And they have established structures. Also at district level there is a meeting or a task team that is sitting to review the district maternal and neonatal mortalities, sitting regularly at district level and even at facility level, like each hospital. They do have such meetings going on.
Review meetings were an important aspect. Perinatal mortality meetings, maternal mortality meetings. And what they've done is to ensure that they occur, that the quality has improved, and that some kind of steps are taken from whatever lessons are learned from those meetings.
Yeah, previously, before they were appointed, we used to have a lot of maternal deaths at district hospital. But after their appointment, there is a difference.
And we are seeing some change because now the CEOs, the executive management of the hospital are now committed to making sure that maternal deaths do not happen unnecessarily, so avoidable maternal deaths are not happening in their facility.
Save the Children South Africa was managing output 2 of the programme, which was strengthening school health services and specifically the integrated school health programme.
The RMCH's role in supporting the Department of Health in the rollout of the ISHP programme was actually from the coordination role, because they are the permanent members of the national test team, whereby they make technical input and direct support at that level, which is the strategic and decision-making level. And furthermore, they were the key role players in terms of coordinating the provincial as well as the district task teams, setting them up, because before they came on board, where the provinces and districts did not have these structures, in existence.
I'd say there was quite a few key achievements actually that managed to happen through the RMCH programme. First of all, the district task teams.
The main responsibility of the district task team is to actually plan the ISHP programme for the year. It involved 5 districts that RMCH was working with, where stakeholders at provincial level were brought together with Department of Education, Health, Social Development, province and the districts. And here too, the main aim was to get the buy-in from all different government departments and NGOs. And this has really assisted us in taking this program forward.
Our focus was initially on the district task teams. We did realise that some of the provincial task teams also were not in existence or were very loosely put together. So actually we then worked to strengthen the provincial task teams as well. So that was something we did over and above what our remit was for the project.
With the RMCH working in Ugu district and with the launch of the ISHP, the integrated approach has helped us a lot.
A key achievement as well through our work with the national ISHP task team was the development of the first health promotion materials for the intermediate phase learners. This is basically a flip chart that's used by the school health nurses, or will be used by the school health nurses, for the grade 4 learners through the HPV campaign. And RMCH was responsible for actually accelerating the development of this.
And also in the schools you have the ILSTs, which is the Institutional Learner Support Teams. Every school was supposed to have these. And before RMCH came on board, these teams were not formed at the schools. So they've played a major role in establishing these teams at the schools. And once the team leaves the school, the ILST continues with making sure that referrals, the child is going to wherever she's referred to, coming back and continuing with the program.
But through the experience that we got through the partnership of RMCH, it was actually very influential, into getting that collaboration between all the 3 departments and through the 3 levels of governance, that is the province as well as the district levels.
The ward-based outreach teams are a key component of the government's, primary health care re-engineering initiative. But they play a very important role because they are community-level health workers, and they will then provide the kind of contact which the health service at the hospital or clinic level wouldn't be able to sustain without going out into the community. So the ward-based outreach teams, in terms of their role for the RMCH services, is really to ensure that community health workers are orientated appropriately on important issues around maternal, neonatal and child health. They have the necessary knowledge to then be able to support mothers in terms of looking after their children, attending antenatal and postnatal care and so forth. So they're a very important link.
We also trained the team leaders because the primary healthcare re-engineering has a stream of ward-based outreach teams. Now, these are led by a professional nurse who is the team leader. We then capacitated that team leader with key messages to family planning so that they can then take that to their community health workers who will have exactly the same messages that are standardized, that are in the facilities that we supported in the districts.
The community health workers were very well
trained on HIV, but not on other programs. Remember, their focus should not be just HIV, because they go out to the community expects them to have a certain amount of knowledge. So we're able to determine that little things like what happens then when a woman bleeds, when they are on the family planning method. Some of them did not have answers. So we started on those basic things so that they are able then to send out the correct messages out to the community.
WBOT are mainly supporting the maternal, neonatal and child health a lot than any other program. So even their leaders as well, the team leaders, they participate a lot also in the issues of training MCWH.
I supported the Gauteng as a RMCH facilitator, Gauteng district, to ensure that their ward-based outreach team are functional in terms of supporting the MCWH program. So what I did there was to work through the sub-district management team, and we included the ward-based outreach team leaders. Together with the sub-district management team, we decided that let's discuss how can a team leader in a ward-based team be better utilized to improve the program of MCWH.
This is a critical component, and there was, I think, good achievements were made during the programs. In all of the districts, the ward-based outreach teams were trained, oriented, and kind of put in place. So I think that was a very important catalyst to now getting this service going.
For the amount of wealth there is in the country, it makes it difficult to understand that every year in our beautiful country, 36,000 perinatal deaths happen. And of those, there are roughly 22,000 stillbirths and 14,000 neonatal deaths. We can't save all those lives, all those 36,000 perinatal lives, but at least half of them are avoidable. And we need to concentrate on that. And our data also shows us exactly where to go. We need to go to the district level, which is why the Minister had appointed the district clinical specialist teams to actually provide clinical governance and support at that level.
For newborn care, we were trained as facilitators for management of small and sick newborn, which now we are training the people in the district who are working with newborn care. We were trained as facilitators for Helping Babies Breathe, which is a program to help resuscitate newborn babies after delivery.
You know, the Helping Babies Breathe and management of sick and small neonates are empowering the healthcare providers who then know how to manage, who then provide better quality of services and impact therefore on the outcomes of our neonates, where we begin to actually see progressively, maybe slowly, you know, with neonates, but we're beginning to see an improvement. And I'm sure that with scaling up of this project, if I can call it that, within the program itself, that we really are going to start to see much more progressive changes, much more significant changes in outcomes of neonates.
So, you know, we often say, small numbers of people with few resources can't make a difference, but we've been able to show through RMCH that we were able to make a qualitative and quantitative difference with respect to neonatal mortality. And it was through simple things that we've been doing, know that we need to do, but we just needed that extra pair of hands, the extra effort, and the discipline that comes with the project.
The role of the SDD was to be the technical lead on the output 3, which was known as demand and accountability. there are particular things that we discovered were happening at the community level and in the minds of the patients that would mean that they would choose anyways not to go to the clinics. So it was things like cultural practices, poverty, challenges with getting transport, concerns with waiting in the long queues. So there were all sorts of reasons that truly needed to be tackled at the level of the community. And it was critical also, we looked at accountability to give voice to the community in letting the health system know what are their needs, what are their challenges, what are their barriers, so that it becomes something that is jointly owned. DFID decided that the way to deal with Output 3 was to provide grants to civil society organizations working on demand and accountability, but to encourage them and fund them to test, learn about, document, and then disseminate innovative approaches that they have tested in the areas of demand.
The three focus areas that we've been actually looking was with regards to peer education for in and out of school youth. Basically this was between 15 to 21 years of age, male and female. The focus of the peer education program was also to look at addressing the barriers and challenges around why teenagers are not accessing primary healthcare services around maternal and child health. The second aspect dealt with the caregiver component. This actually related to three aspects, one being information sharing, the second being health promotion, and the third being encouraging referrals of pregnant mothers, adolescent mothers to primary healthcare services. And the third being the client transport fund, that looking at a barrier of why people are not accessing primary healthcare services. The results from what we've basically started to roll out, one was that we've seen a clear significant decrease firstly in teenage pregnancies. Secondly, we've also seen a very significant reduction in school dropouts. And thirdly, we've seen a real big increase with the examination outcomes, with the school outcomes.
I think we had an impact on accountability as well. Black Sash, for example, was able to demonstrate the merits of doing scorecards, of organizing sessions, first where you gave separate voice to community and to health workers, and then to bring them together collectively to develop action plans. So I think we also left with concrete actions that were taken as a result of communities and health workers coming together based on prioritized issues that they felt needed to be tackled in their communities. And then those things, by being documented, became tools that other districts and other stakeholders could use.
It's very important for us to use data to know what's happening in our programs. And as I said, we want to reduce mortalities in particular, but also some of the morbidities. And we have, through RMCH, created a dashboard very successfully, both at the national department, at provincial department level, and in the districts. And RMCH has assisted us in both developing the dashboard, but more importantly, getting the districts to use the dashboard.
So the dashboard system is an attempt to take indicators that measure health status or health outcomes and display them in a way in which people can see quite easily whether they're improving, staying the same, or going backwards. So at a district level, my experience is by and large people have found this very useful, and we've had a number of provinces asking us for the tools and the methodology, so they don't have to wait for national department to give them the dashboard, but they'd like to do it themselves because they have the data far sooner than the national department has it, and they can do it immediately.
One of the key instruments that we've been using in the RMCH project is to design information, booklets, video material, a website that I think was quite well designed and also easy to access, and also the discussion lists. So we had discussion lists with our district clinical specialists that was hosted and run by RMCH. And I think the extent to which we've been able to convey information and receive information from the ground has been quite impressive with the RMCH project. So it's played a very important role in both keeping people informed about what we were doing, but more importantly, hearing from the ground what they think is happening or should be happening.
The ESMO-E program is a program aimed at improving the obstetric and neonatal emergency care throughout the country. The RMCH has played a vital role in the form of the District Clinical Specialist Team. In the areas where we've performed saturation training, which means where we have trained more than 80% of all healthcare workers in that facility, and then in that district, the district clinical specialists have been integral in organising and training of those situations. They've further been integral in the follow-up and doing of the emergency drills that are part of the training program.
So a fire drill is a dry run of how you would respond in an emergency, and I mean there's a reasonably small subset of life-threatening common emergencies in obstetrics, and the idea is that the team is primed to respond to those quickly and efficiently and make sure that the right things get done. And so the idea of a fire drill is really to run through that and to pretend it's happening and to go through it as a team as if it were for real, and then to sit down and analyse that. And it's been really exciting to see how familiar people can get with managing severe emergencies. I can remember in the early days here really needing almost to direct proceedings as the doctor on scene in an emergency, but now I often just feel like the spectator, because really what's happening is happening and people know what they need to do and they do it. And so that's the intention really.
Very fortunate in the support that RMCH has given us in making the training materials, the difficult caesarean section done by Eckhard Buchmann and by the postpartum hemorrhage done by Sue Forkas and Jack Mudley. We have developed a totally new module in ESMO around the caesarean section, which is based around the difficult caesarean section and the video. This was necessary because a third of all the deaths due to obstetric hemorrhage are related to bleeding at or after caesarean section, and 5% of all deaths in the country are related to bleeding at or after caesarean section. So this video is an essential tool for us to be able to go to each district and spread how to do safe caesarean sections. We are currently in the process of going to every district with this module in a refresher course. And so we run this course, and this course will be run throughout the country within the next year.
In maternal and child health in South Africa, we actually have very good policies in place. So we know what our problem is and we do have what to use. But the problem is that we are good at planning, but we seem to have a problem with implementation.
CARMMA is a campaign and acceleration of reduction of maternal and child mortality in Africa, which was launched at Stulele on the 15th of October 2013. And the good thing about it is that when the CARMMA was about to be launched, you know, there were many reasons. Women were dying, children were dying.
We as the hospital have been engaging, but through the RMCH process and CARMMA, the traditional leaders were also engaged because they're an important stakeholder in this community. And at the CARMMA launch, the head of the Traditional Leaders Association was able to stand up and say, we have made a decision as the traditional leaders that we're not going to give traditional medicine to sick babies under the age of 6 months. And for us, that's a huge win.
UKAID ndibulela kakhulu okokuqala ndibulela eliphulo lika CARMMA kangangoba ngendivuba kuthiwa liyaphinda futhi liyaqhubeka njengoba sime apha sisokola ngamathina wobisi labantwana ngoku abantwana kwathiwa mabancancise abadlezana abazalayo sifundile ngogonyo abantwana bagonywe laa nto ibethwayo apha umntana sobezelwe abaleka asiwe eligonyweni akuthiwa zikhangori abalapha kule maternity esiye sababona ke abafakwa ngaphakathi bakhuliswe ngendlela ozapha esibhedlela balinde apha esibhedlela bazohlala apha kuthiwa ke i-waiting mothers kayibiza ke ngokwesilungu. Siyayibulela kaphaya kuyaphekwa kwenziwa yonke into bahleli nje kamnandi umfazi ke ngoku asosala apha ematernity esalufumana kwesi sibhedlela ngenxa kaCARMMA owazisa iprogram kwesi sibhedlela. Enkosi.
RMCH also assisted us as this institution where we're having some gaps, you know, helped us to sort of have a plan to improve, you know, quality improve, how to improve our quality in terms of delivery of services in maternity.
RMCH supported the family planning campaign, obviously because it's an entry point to women's health. If we succeeded in family planning, we would obviously have a great impact on the reduction of maternal deaths or neonatal deaths, you know, preventing unwanted pregnancies. The Implanon is a new contraceptive method that has recently been introduced by the National Department of Health in order to assist women, you know, because it's long term. This one is inserted into a woman's skin and it lasts 3 years.
Enye into ke esivuyeleyo yindlela esiye sanikwa yona olucwangciso le Implanon. Leya ke ngoku iyathandwa ngabantwana bale ndawo.
So RMCH was also responsible for national training of all the trainers for the Implanon and the family planning.
We then said to close the tap, success will come from looking at the community level of care. So community level of care, we then worked together with Yvonne Chaka and created messages that were key to sell the family planning understanding to the community. So we came with the song Let's Talk, which is sung by Yvonne Chaka and has messages from a youngster, the rapper called Reason.
The impact of teenage pregnancy in the country is huge. It affects us very negatively in many spheres, in health, in education. It also affects us socially.
I think, you know, we've got a great Minister of Health, Minister Motsoaledi, with his whole team. They asked me to do this project about teenage pregnancy, and I think because I'm a mother of 4 boys, and I want to encourage girls as well. I'm an activist. I just feel girls and women are still disenfranchised.
Children at a certain age engage in sexual activity. We need to understand that it does happen, but prepare our children for that. Educate them appropriately. We need to have this education in schools. We need to also have community engagements and discussions, and we also need to use our celebrities to start messaging suited for the young ones so that they can know how best to prevent early pregnancies.
The Let's Talk song has all those messages to say this is the time. Maternal deaths are increased by the teenagers who get pregnant. Their bodies are not ready to have babies. They complicate during delivery. And the only way we can help them save the mother and the baby, they are not listening to us, is to close the tap. Family planning is the key.
The Minister of Health wanted to launch a program for pregnant women, an mHealth program for pregnant women. And RMCH came in with a whole team of people to support the Minister to take this program to the provinces. But certainly the processes of this mHealth program for pregnant women has been well taken up. And since August last year, over 400,000 women, pregnant women have been linked up to getting SMS messages on a weekly basis. And they seem to enjoy getting it because the compliments outnumber the complaints by about 5 to 1.
The RMCH Operations and Finance Unit has direct responsibility for all program management activities that is for the RMCH program, including our partners. Linking to key achievements, the operations and finance unit, I think the key ones that we can talk about from a program management perspective were firstly the MTR, which is the midterm review. There, the RMCH had a threefold role. The first one was we acted as secretariat. Secondly, we were also program managers. That meant that we had to oversee all the meetings that were held in the districts within the 9 provinces. When you look at it in terms of financial management, Futures Group was awarded the RMCH program based on its strength in managing finances. And for us as a program, we were able to ride on that. We had robust internal controls. Our procurement systems were thorough. We also had a tight budget tracking system, which also helped us to monitor and track our expenses. There were key best practices that we had as the RMCH program. One of them was the Program Management Manual. It provided a guideline and set standards for us to be able to follow. And we can actually say, if you look at the RMCH program, whatever has been done and shared with partners and grantees was standard, it was systematic, and it also produced a standard of excellence because everyone knew what they were supposed to contribute and do.
The legacy of this program comes from having been able to achieve the 3 gaps that DFID designed this program for, which is translating knowledge to action, strengthening local leadership at a district level, and strengthening service delivery, quality, and access. Before RMCH, the emphasis on maternal and child health was not there, and the communication in terms of people knowing about maternal health services, where to get them, the importance of attending antenatal care, the importance of delivering in a facility by a skilled birth attendant. Much as it was just information, but there was no emphasis in involving the communities and creating a hype, including the civil society organizations, so that they can know what part to play as well to improve service access, to improve service utilization, but more importantly, to take part in reducing the number of deaths that we are seeing of mothers and children. And I think the program was able to do that through just wide dissemination of policies. And I think the dashboards are one of our biggest legacies that we are leaving for maternal and child health. Because the program, when it was started, there were different sources of data, and there were many indicators of reporting for maternal and child health services. But now I think there's a more systemic way of reporting through the use of the maternal and child health dashboard. The last one I think has been the emphasis on knowledge management, which was a new thing. Much as there has always been emphasis on the use of data, there has been emphasis on the use of reporting against indicators, but the other part, which is the use of information and managing and harboring knowledge, capturing lessons, capturing best practices, with the minister now looking at leapfrogging, which is about scaling up things at speed and with wider coverage. I think putting in knowledge management in program management is going to be one key factor.
So what are the key achievements that resulted as a result of the RMCH program? One was the dashboard for at a district level, sort of showing performance on a range of indicators, improvements in neonatal health, which is one of the key problems in South Africa that has been difficult to change. The third would be a little bit on demand creation and getting women to attend antenatal clinics earlier, which is one of the key factors around improved both maternal outcomes and neonatal outcomes.
The technical assistance provided and the skills and knowledge shared has therefore not only impacted on the healthcare providers in the facilities in the districts, but for me as a chief director new in the department, it's been quite incredible. And I must say, the support therefore, once again, yet another example that shows how things may have gotten done, but not as well, not as quickly, not as effectively and efficiently without their support.
What we have been able to show empirically through the RMCH project, and if we just take two indicators, the ESMO-E project and the neonatal project as two projects, you could see that in the districts that we intervened with respect to maternal mortality, we were able to decrease it by 30% and neonatal mortality by 35%. So, and these are directly attributable to the interventions through RMCH, but because we wanted to make it sustainable, it was through the district clinical specialists as well as the other components of the primary healthcare team that were in those districts. So I'm quite confident that with the resources that we built up in these districts, that we will be able to sustain those gains. What we need to do, however, is to ensure that through our own resources, now that the RMCH project is coming to an end, that we are able to scale up those resources to all of the other districts in the country. And we think we have the modalities, the models, the communication tools, and all of the material that we need to do that. Will I be sad that they're leaving? Yes.